Respected Emeritus Chairperson, Dr. M.S. Vankasa, respected Vice Chancellor, Dr. Salgulati sir, Principal Dr. Soni sir, Dr. Sasdev sir, Senior Dignitary, faculties, dear students. We are going to present CCR on behalf of Unit 1, Department of Orthopedics. So before we actually come to the CCR presentation, I will give you a very brief and quick overview of the department. We are 4 professors, 1 associate professor, 8 assistant professors, 5 senior residents, and with 9 PG seats each year, we have 27 residents. These are the 4 units. Besides normal orthopedic output, we have some specialty clinics running on each weekdays. Last year, we have successfully performed about 1,533 surgeries. There are certain surgeries which are done at a higher center, and I'm glad to share with you that complex pelvic acetabular surgeries are very well managed at our center, and over 200 cases of complex pelvic acetabular surgeries have been done so far. Complex surgeries involving shoulder include fracture dislocations of the posterior fracture dislocations of the shoulder, and hemiarthroplasty, reverse shoulder arthroplasties, which we are doing. In the spine, we are doing corrective scoliosis surgery, transforaminal lumbar intervertebral fusion, PLIF spinal decompression with fixation, laminectomy, ischectomy, etc. And so far in past 1 year, we have done 41 spinal procedures. We are doing partial knee replacements, 10. In the last 1 year, we have done 10 such cases, 39 total knee, 28 total hip, and 98 bipolar hemiarthroplasties. These are some of the post-op radiograph pictures of the cases that we have done. We are also doing THR with direct anterior approach, which is currently in vogue latestly. We are routinely doing arthroscopic surgery for the shoulder and knee for ligament reconstructions and debridement, etc. In the past 1 year, we have done 558 arthroscopic procedures. We are also doing bone tumor cases, and in 3 cases we have done excision of the tumor with extracorporeal radiotherapy sessions. These are done along with the collaboration of Department of Radiotherapy, Department of Surgical Oncology, and Department of Plastic Surgery. We have done 16 oncologic surgeries during the last 1 year. We have also done 5 cases of post-COVID-19 avascular necrosis of the hip, where we preserved the hip using vascularized fibular grafting procedures. We have total 83 publications so far, 18 publications in the last 1 year, 17 publications have been done in PubMed recognized journals. We are also doing academic activities, and there are some personal achievements by the faculty members. Only recently we did a sawbone workshop in our experimental lab, where our PG residents learned the basics of the total knee replacement. So with this, now I would call upon Dr. Rishabh Saxena, second year resident, to start proceeding with this case, which is a young patient with spinal deformity and limping gait. Dr. Rishabh.
Good morning, Honorable Emeritus Chairperson, Dr. M.S. Vankasa sir, Honorable Vice Chancellor sir, Dr. Achal Gulati sir, respected Principal and Controller, Dr. N.D. Soni sir, and all the faculties present in the audience. I, Dr. Rishabh Saxena, second year resident from the Department of Orthopedics, is presenting a case of a young patient with spinal deformity and a limping gait. Moving with the history part, an adolescent female student aged 15 years and a resident of Ramgarh near Jaipur came to Mahatma Gandhi Hospital in our OPD with the chief complaints of progressive mid and lower back deformity for the past 5 years, with limping since last 5 years. The history of presenting illness is she was apparently normal till 10 years of age. 5 years ago, her mother noticed a hump in her mid and lower back, which was gradually increasing. There was also tilting of trunk towards the right side for the past 1 year, and she started limping towards the right side. There is no paresthesia or weakness in the lower limbs. There is not, which is not associated with any kind of back pain. There is no history of morning stiffness, lower backache, and no peripheral joint involvement. There is also no history of fever, night sweats, weight loss, and trauma. 3 years ago, she consulted for this deformity when she was 12 years old at some other hospital and was advised observation with regular follow-ups at 6 months interval. But she didn't go thereafter. There is no history of any previous chronic illness, surgery, or hospital admissions. Her personal history was unremarkable. She achieved menarche at the age of 14 and a half years, which was 6 months before she came to her OPD. Her birth and developmental history. She was delivered by cesarean sections and her milestones are normal for her age. Her family history is insignificant as her parents and 3 siblings are healthy with no similar complaints. So, what could be the possible diagnosis based on the history? Anyone from the audience? Yes.
Congenital pathology.
Okay. Yes, congenital condition can lead to such complaints. Anyone else? Yes. Since there is no complaint of any pain, numbness, or weakness by the patient, so PIVD is very less. So these complaints can be due to a neuromuscular cause, which can be due to a upper motor neural lesion, a lower motor neural lesion, or a myopathy. It can be due to a structural deformity of the spine, which can be a kyphotic one or a scoliotic one. The upper motor neuron can be due to congenital. The upper motor neuron neuropathies can be due to a congenital cause, a cerebral palsy or a spinocerebellar degeneration, a traumatic or trauma to the spinal cord, syringomyelia or a spinal cord tumor. A lower motor neuron can be due to an infective pathology, poliomyelitis or any other viral pathology. Traumatic, a congenital such as a Charcot-Marie-Tooth disease or a spinal muscular dystrophy. It can be due to a myopathy such as muscular dystrophy, arthrogryposis, congenital hypotonia or myotonia dystrophica. Let's discuss about the structural causes. The first one is the kyphotic one. Kyphosis is a normal curvature of the spine. If there is exaggeration in the forward curve exceeding more than 40 degree, then it is a kyphotic deformity. It can be due to bad posture, postural kyphosis. It can be a compensation to preserve the sagittal balance, which is a compensatory kyphosis. It can be a Scheuermann's disease, which is also seen in adolescent age group. It can be an ankylosing spondylitis as well as senile kyphosis. Since the history provided by a patient, the age based on the age group, we can easily rule out the senile kyphosis. And we also got the negative history of any kind of morning stiffness or lower back pain, so we can rule out ankylosing spondylitis. These 3 are still in the picture. The other kind of spinal deformity is the scoliosis. Scoliosis is a lateral curvature in the spine. It is a 3-dimensional deformity in the coronal, sagittal, and there is also a third rotational component of the spine. It can be a mobile scoliosis, which is correctable on performing maneuvers such as posture or limb length discrepancy, pelvic obliquity, or sciatica. Or the other one can be a structural scoliosis, which can be a congenital one, neuromuscular, and idiopathic scoliosis. Idiopathic scoliosis presents at various age groups. Accordingly, it has been classified into infantile, juvenile, and adolescent group. Moving forward with the clinical examination. General physical examination, her vitals are normal. Moving towards the systemic examination, all systems are normal. Now, inspecting the patient from back and standing position, we took consent of the patient to display her pictures without revealing her identity. In the right picture, the clinical picture of our own patient, we look for the position of the head, which is centrally placed. The trunk is tilting towards the right side. As we look at the shoulders, the left shoulder is higher than the right one. The left scapula's medial border is more prominent than the right one. We can also see that there is a curvature in the spine, which is convex toward the right side, and the left pelvis is higher than the right. There is no dimpling, hair patches, or skin pigmentation with no abnormal swelling. Now I would like to highlight this, and if anyone from the audience can answer why we are looking for hair patches or skin dimpling. Yes?
Spinal, it can be spinal bifida.
Yes, correct. It is a spinal bifida is a congenital defect of the spine, which can lead to. Sir, yes, sir.
three types of spinal.
Yes, sir.
What type of spinal you have?
Sir,
In case if this implementation happens, which type of?
sir, it can be occulta one since it was missed in this age group, sir. Till 10 years, she was missed with this diagnosis.
What are the two others?
Sir,
मैनिमोसिल and
meningomyositis.
माइलोमेनिमोसिल क्या होता है? सबसे सीरियस कौन सा? न्यूरोलॉजी डिपार्टमेंट, ऑर्थोपेडिक, स्पीक.
Looking at the picture on the left, sorry.
So associated with anarchia and malformation type 4 if it is present in the cervical region so mostly it is seen in the cervical region with anarchia and malformation. Apart from that, it can be present in the lumbar region also, which can be seen with tethered cords in spinal
Looking at the picture on the left, we draw two lines which are from the lateral border of the pelvis extending upward. This shows the normal alignment of a spine. Coming to our patient's clinical picture, we draw two black lines coming from the lateral part of the shoulder downwards. Ideally, these two lines should have coincided if the alignment was normal, but this picture clearly shows that the patient has a coronal imbalance. We can also see on inspection that there is a razorback deformity on the right side, which is due to an angular rib hump. The left shoulder is higher and there is a difference between the level. This is a video of a patient walking, preoperative video. As we can see that the patient has a bipedal gait with a trunk. As we can see in this video that the patient has a bipedal gait with a trunk tilting towards right. Her pelvis is higher on the left and she's walking with a limp towards right. On inspecting from front, the prominence of the chest is more on the left side. This is also due to the rotation. On inspecting from side, we can see, although the left clinical picture is not of full length, but she has a sagittal balance which was examined clinically. Picture on the right, a line is drawn from the external auditory meatus passing through the shoulder, pelvis, knee and the lateral malleoli. It comes a straight line. This shows that the sagittal balance in the patient is maintained. It was also examined in our own case. Looking in the lower thoracic region, hypokyphosis is seen and there is a right rib hump seen. Moving with the palpation part, all inspectory findings were confirmed on palpation. There is no local rise in the temperature and no tenderness seen. In the paraspinal region, there is fullness present on the right side and the hump, the deformity felt is on the right side. There is also a positive coronal balance towards right side, confirmed clinically to be 4 cm. On palpating the deformity, the curve appears to be starting from T8 vertebra with its apex at L1 on the right side and the curve is ending at L5 vertebra. On performing this specific Adams forward bending test, the patient is asked to bend forward with the knee extended. The patient is asked to bend forward with the knee extended. As we can see in the clinical picture, the deformity is still prominent. This shows that the deformity is a structural type of deformity. If in some other case on bending forward the deformity disappears, then it is a correctable kind of deformity. We also examined the patient in sitting and lying down position. The curvature was still persistent. This also confirms that the deformity is structural. Rest all findings were similar as in the standing position. Moving with the range of movements part, in the cervical region, all movements are pain-free and within normal range. In the thoracolumbar region, all movements are pain-free, but there is a decrease in flexion and extension. The lateral tilt is more towards the left side and the rotation is more towards the right side. On examining hip, knee and sacroiliac joint, the movements are pain-free and within normal range. This helps us in ruling out the postural cause for the deformity. Further moving with the neurological examination, in the first we examine the motor system. The bulk tone power reflexes are normal in upper extremity and lower extremity and there is no apparent or true limb length discrepancy. with no pelvic obliquity. For then examining the sensory modalities, all sensory functions were normal in a patient. What can be the provisional diagnosis based on the history and the examination we just did? Since we palpated the patient and the deformity was a lateral curvature of the spine, so we can easily rule out all the causes of the kyphosis. Now we are left with the scoliosis part. We performed a specific Adams forward bending test, and we saw that this curve was still prominent. So this rules out the mobile part of the scoliosis. We also did the neurological examination, which was asymptomatic, so we can rule out the neuromuscular scoliosis. The age group of the patient does not support the infantile or the juvenile one, so we can also rule it out. To sum it up, we are left with the provisional diagnosis can be a congenital scoliosis or an adolescent idiopathic scoliosis. I would like to invite Dr. Sakshi ma'am to enlighten us on the development of spine.
Good morning everyone. Myself Dr. Sakshi from Department of Anatomy, and I am presenting the embryological basis of development of vertebral column and the spine. So the development of vertebral column generally takes place from the somites, which is derived from the paraxial mesoderm, and the somites ultimately differentiate into a ventromedial part which will form the sclerotomes, and it will be responsible for the further formation of the vertebrae and the vertebral column. Now, as we can see in the picture, this is the part. This is the sclerotome, which is ultimately having an embryonic tissue, which is known as mesenchyme. These cells become large and polymorphic, and ultimately they are migrating towards the midline, that is near to the notochord, and ultimately they condense around the notochord to form various parts of the vertebrae. Like around the notochord, it will be condensing to form the centrum, that is the vertebral body in the adult. Around the neural tube, these cells will condense to form the right and left neural arches that will ultimately give rise to various parts of the vertebrae like the pedicles, the spine, the articular processes, and the costal part of the transverse processes, and the body wall, it will be forming the costal elements of the vertebrae. So after the migration, yes sir.
Speak of pregnancy के चालू होता है
Sir, it is at the 15th day of the pregnancy, the embryonic and embryonic life. Yes sir. Yes sir. Yes sir. Sir, it completes around by. Sir, you're asking for neural tube, no? And notochord. So by 3 to 6 years, it is complete. No, sir, not neural tube. Sir, I'm talking about the vertebral column.
Complete spinal cord, brain, everything. What time pregnancy? What weeks of pregnancy?
Sir, by the 3rd week of pregnancy.
But the start होता है, कब complete होता है? Brain development.
Yes, sir.
Structural development.
Yes, sir. Sir. Yes, sir.
Any resident from any department? By 11 weeks it is complete. What is the do the test?
Yes.
The neural tube defect. What are the tests? Common test. होता क्या पहले?
Sir, anomaly test.
होता क्या?
Sir, in order to identify any
कुछ विटामिन्स देते हैं प्रेग्नेंट
folic acid.
बेसिकली फॉलिक एसिड
Yes, sir. Yes, sir.
हॉस्पिटल होती है B1 B2 B3 B4 B9 कौन सी Ganesha B6 it is B9 B6 this is B9
Being yes.
that is for pregnant patient with the iron
Folic acid.
folic acid you start giving before pregnancy
Before pregnancy also.
to prevent the neural
Yes.
by 11 weeks whole brain and spinal cord is developed. First trimester जब बच्चा पैदा होता है उसमें पूरा डेवलप होता है and it goes
Yes. So now the mesenchymal cells ultimately form segments of the somites, and the central segment become more condensed, and ultimately the rest two segments, that is the cranial and the caudal segments, they are less condensed, and ultimately both of them are involved in formation of a vertebra, but of the adjacent somites. So cranial half of one somite and caudal half of another somite will combine to form one vertebral body. Now coming to the classification of the congenital scoliosis, which was given by Winters, Moe and Ehlers. There are two types of classification. First is failure of formation of the vertebral body, and second is failure of segmentation. So in case of failure of formation, we are having two types, that is partial unilateral failure of formation and complete unilateral failure of formation. In partial unilateral failure of formation of vertebral body, only one side of the vertebral body will be formed and rest side will be incompletely formed. It is not completely formed due to the failure of formation. Same ways, in the complete unilateral failure, only one side of the vertebral body is formed. So in the first case, there is formation of a wedge vertebra, whereas in the second case, there is formation of a hemivertebra, that is half of the vertebra. This is the first case. In the second condition, there is failure of segmentation. In failure of segmentation, we are having unilateral failure of segmentation, which will give rise to a congenital bar. And in the second case, we are having bilateral failure of segmentation, in which we are having a blocked vertebra. So here, the caudal and the cranial end of the vertebrae are not segregating from each other on one side in the first case. So we will be having a congenital bar formation. Whereas in the second case, on both the sides, the segregation does not take place, and ultimately there is a block kind of vertebra which is formed. So in our finding, none of the above applies. Yes, so I'll hand over back to Dr. Rishabh. Thank you.
Thank you, ma'am. On moving towards the investigation part, we request for some radiological investigations of the spine, such as X-ray, MRI, and CT scan. We also evaluated other systems for cardiac and renal system anomaly, as they are found to be associated with congenital scoliosis. Moving towards the X-ray part, the aim is to differentiate the type of scoliosis among the congenital and the adolescent idiopathic, to see the extent and magnitude, the end vertebra and the apical vertebra, to see the flexibility of the curve. We request for the AP in the lateral view of the spine in standing position, and the bending films in the right and the left direction. We also request for the traction X-ray. The CT scan is done to see the anatomy of pedicles and the bony status of the spine for surgical planning. The MRI is done to see the intraspinal pathology if we are planning to operate or any abnormal neurological finding is seen. This is the AP, erect and the lateral view of spine, showing dorsolumbar scoliosis with its convexity towards the right side. The curvature is extending from the T8 till L3 level of the vertebra, with its apex at T12 on the right side. This is a line diagram showing to calculate the Cobb's angle, the end vertebra and the apical vertebra. The curvature, the purple part, the uppermost or the proximal end vertebra is the most tilted, and we draw a line parallel to the superior end plate from this vertebra. Another line is drawn from the distal part of the curvature or the distal end vertebra, a parallel line from the inferior end plate. Two perpendicular lines are drawn from these parallel lines, and the angle made is the Cobb's angle or the K angle. Basically, this angle is the magnitude of a curvature. This is the X-ray of a patient. The blue one depicts the proximal and the distal end vertebra, and the green one depicts the apical vertebra. The Cobb's angle was 91 degree in our case. We further assess the coronal alignment. We draw a line from the center part of the sacrum, which is known as the CSVL or the central sacral vertical line. We draw another line from the spinous process of the C7 vertebra extending downwards. This is a plumb line. Ideally, these two lines should have met in the center or they have coincided, but in our case, there is a distance between the two. This signifies that the patient has a coronal imbalance. Traction X-ray is done to see the flexibility of curve, and the Cobb's angle in this is 60 degrees. The bending films are done in the right and the left direction in the supine position, and the right bending film, the Cobb's angle was 78 degrees. So what we got from the X-ray, we got to know the upper end vertebra of the curvature, which was T8 vertebra. The lower end vertebra was the L3 vertebra, and the stable vertebra was the L5 vertebra. Now I will invite Dr. Ishika to discuss the CT and the MRI scans of a patient.
Yes, and my dear colleagues, I will be discussing the CT and MRI findings of this case. These scans were performed somewhere else and not in our department. These are coronal reformated images of NCCT spine, which shows that there is dorsolumbar scoliosis with convexity towards the right side. There is no evidence of any fracture, dislocation, or osseous abnormalities such as hemivertebrae, block vertebrae, or butterfly vertebrae. These are volume rendered CT images which shows that there is dorsolumbar scoliosis extending from the level of T8 to L3 with the apex at T12 level. We calculated the angle of curvature by Cobb lip hand curvature method, which came out to be 91 degree. These are MRI T2 weighted sagittal images which shows that normally the spinal cord is dark grey in appearance. But in our case, as we can see that there is increase in intensity of the spinal cord throughout its entire length. These findings are suggestive of syringohydromyelia. There is also no evidence of any intramedullary mass lesion. These findings are confirmed on MRI T2 weighted axial images, which shows that there is syringohydromyelia with parenchymal thinning. These are MRI T1 weighted sagittal images, which shows syringohydromyelia dark grey in appearance. Normally, these are T2 and T1 weighted sagittal images of MRI. Normally, cerebellar tonsils are above the level of foramen magnum or maybe 2 to 3 millimeter displaced below the level of foramen magnum. But in our case, as we can see, that the cerebellar tonsils are peg-like in shape and they are caudally displaced 9 millimeter below the level of foramen magnum. So these findings are suggestive of Chiari malformation type 1. Since the scan was suboptimal, it is very difficult to delineate the spinal cord. But here we can see in the T2 weighted sagittal images of lumbar spine that the spinal cord is ending approximately at the level of L1, L2. There is no evidence of any T3rd cord. To conclude, the above findings of CT and MRI are suggestive of dorsolumbar scoliosis with convexity towards the right side. There is syringohydromyelia associated with cerebellar tonsil descent, suggestive of Chiari malformation type 1. Now, I would like to call Dr. Ishak to continue the presentation.
Thank you. Since on MRI, syringomyelia and Chiari malformation type 1 was reported, so neurosurgery opinion was taken, and since there is no neurological deficit on clinical examination in the upper and the lower limb, so no neurological intervention was required and advised for observation. Some basic blood workups were done and they comes up to be normal. So what should be the final diagnosis in our case? Initially we were left with the congenital scoliosis and adolescent idiopathic. Since in our case we did not see any wedge vertebra, hemivertebra, block or the bar vertebra, so we can easily rule out the congenital scoliosis. The summary is there is a progressive paleness dorsolumbar scoliosis with Cobb's angle of 91 degree extending from T8 to L3 vertebra without any neurological deficit in a 15-year, 6-month post-menarche female with a positive coronal balance. The diagnosis is adolescent idiopathic scoliosis with Chiari type 1 malformation, which was asymptomatic and without any neurological deficit. So the question is, how do we manage such a case? So first we calculate the Cobb's angle. If the Cobb's angle is less than 25 degree, observation is advised. If the Cobb's angle is between 25 degree to 45 degree, then the patient is counseled for bracing with regular follow-ups at the 6-month interval. If the Cobb's angle is more than 45 degree, then surgery is indicated. Since in our case the angle was 91 degrees, so we advise for surgery. Now I would like to invite Dr. Aditi to discuss the anesthetic workup for our patient.
Good morning, respected teachers and my dear colleagues. I'll be discussing the anesthetic management for this case. Now, what are our anesthetic considerations? First, general anesthesia with restrictive lung pathology. So we ordered PFT, that is pulmonary function test. In our case, just mild restriction pattern was seen. Then prone position. As you can see in this picture, this is just a depicted photograph for explanation purpose. As you can see, all the pressure points are padded like elbow, axilla. Neck should be in neutral position. Face in soft head ring with no pressure on eyes and nose. The shoulders with small degree of interior flexion, abduction and external rotative to less than 90 degree. And abdomen should be free to prevent increase in intra-abdominal pressure and preserve pulmonary compliance. Next, intraoperative neuromonitoring, long duration of surgery, anticipated major blood loss. So we ordered 3 to 4 units of PRVC in advance. And deliberate controlled hypertensive anesthesia was used to control blood loss and turning back to supine from prone position after completion of surgery. Moving on, intraoperative monitoring. First, routine monitoring as per standard American Society of Anesthesiologists recommendation, ECG, oxygen saturation, blood pressure, urine output and temperature. Then intraoperative management, standard general anesthesia induction was done with flexometallic tube to prevent kinking, as you can see in this picture. Left radial artery was cannulated with 20 gauge radial artery cannula. We applied warming blankets and gave warm IV fluids and irrigation solutions to prevent hypothermia. Then special monitoring, invasive arterial BP monitoring was done. Train of 4 for neuromuscular monitoring, bispectral index to know the depth of anesthesia and intraoperative neuromonitoring for motor evoked potential. Now, what is bispectral index? It's a value which reflects the level of consciousness of the patient. It involves application of 4 electrodes on the forehead, as you can see in this picture. The BIS value normal is from 0 to 100 and for recommended range for general anesthesia for surgery ranges from 40 to 60. This is available in our institution. Now, motor evoked potential. Why it is done? It is done to minimize the risk of injury to neural pathways during spine surgeries. It assesses the central motor pathways within the brain and spinal cord during surgery. This is corkscrew, which is applied 1 to 2 cm ahead of coronal suture, which represents the motor cortex area, from where the stimulation starts. And mirror electrodes are placed on 4 muscles: abductor hallucis longus, tibialis anterior, gastrocnemius and thenar muscles. This is the monitor showing the graph of MEP, and this is motor pathway. The stimulation starts from motor cortex, goes down from cervicomedullary junction, spinal cord, arm and leg. And on NMJ we get compound muscle action potential. Now, what are special considerations while doing MEP? First, most importantly, we should avoid neuromuscular blocking agent and avoid high doses of inhalational anesthesia, hypertension, hypoxia and hypothermia. Otherwise, these factors will cause interference with the graph of MEP, like decrease in amplitude and increase in latency of muscle action potential. So these should be avoided. To control blood pressure and to prevent awareness, infusion dexmedetomidine was used. This is a printed checklist for neuromonitoring changes during surgery. If there are any signal changes in the MEP, then this checklist is to be followed. Total duration of surgery was approx 10 hours. ABG was done every 4 hourly to know electrolytes, hemoglobin and glucose. There was estimated blood loss in our case 1100 ml. So 3 units of PRVC was transfused. Now, what are post-op concerns? Overnight elective ventilation was opted because of pre-op chest deformity, long duration of surgery and blood loss. So patient was extubated next morning in ICU. For pain management, injection fentanyl, injection PCM and fentanyl patch was given. And incentive spirometry and deep breathing exercises were advised to optimize the pulmonary function, which were already started in preoperative period. Thank you. Now I would like to invite Dr. Nihal Gomes, Senior Resident, Department of Orthopedics, to enlighten on surgical management of this case.
Good morning to all the dignitaries. I'll be speaking, Dr. Nihal, Senior Resident from the Department for Orthopedics, will be speaking on the surgical management of scoliosis. So what are the aims of our surgery in scoliotic correction? It was to adjust the coronal and sagittal balance, to halt the progression of the curve, to correct the deformity without causing neurological worsening. This goal is to achieve a stable, non-progressive, balanced spine without neurological worsening. In our patient, the patient had achieved a peak height velocity and menarche had already been obtained. Hence, if this had not been obtained, we could go ahead with the anterior fusion and fixation method. The combined approach in which is the anterior and posterior fusion and fixation. But since in our case menarche had been achieved, peak height velocity was already achieved, further growth spurt would be minimal. Hence, the surgical technique we obtained was posterior fusion and fixation. We went ahead with the surgery. We did a posterior fusion and fixation and a posterior lateral fusion from T8 to L5. The surgical steps that were performed were the positioning of the patient, neuromonitoring attachment and baseline reading, exposure, corrective osteotomy with decortication to make a fusion bed, pedicle screw instrumentation, we rechecked the neuromonitoring reading, correction maneuvers were followed, again rechecked neuromonitoring, bone graft placement over the posterior lateral fusion bed, and closure with drain in situ. Coming to a detailed explanation, this is a patient position of our own very patient in prone position. All the bony prominences were well padded, abdomen was free. Neuromonitoring attachment and baseline reading was taken. This is a clinical photograph of our patient in which this is the head end, this is the foot end, this is the right side where the surgeon is present. A standard posterior midline incision is taken from the upper end of T8 spinous process to the lower end of TL5. We took a long enough incision to allow convergence of the pedicle screws in the uppermost vertebrae. The spine is exposed to the tip of the transverse process bilaterally but staying subperiosteally to reduce bleeding. We followed out of various corrective osteotomy methods, we followed a Ponte's osteotomy. Here, corrective osteotomy with decortication to make way for bony fusion was done. Here, the spinous process was taken out, laminectomy was done, fascicectomy and posterior ligaments were removed. This was done to release the stiffness of the curve, to better assess the pedicle's entry point, and to harvest a localized bone graft. Then we went on to the pedicle screw fixation. This is a very delicate procedure of locating the pedicles and meticulously fixing each pedicle screw, which takes a lot of time. Hence, such cases we make use of an O-arm, but it was not available at that point of time, so we made use of a fluoroscope. Herein we fixed. Yes, sir. Herein we fixed 14 pedicle screws, and after each screw fixation, we rechecked neuromonitoring. At every 15 degrees rod rotation, fixation was stopped once coronal balance was achieved or further correction was not possible. Correction maneuvers that were followed, these were done simultaneously and at multiple times. After correction, we rechecked neuromonitoring reading. This is the most important step, was to achieve a posterior lateral fusion by placing of bone graft. As we can see in this clinical photograph of our patient, we can see bone graft placement was done. We can see that the bone grafts that were harvested during osteotomy were placed in form of to form a posterior lateral fusion bed.
It's a photograph I impressive. It's surprising. And if it is there, then I'm congratulate. Real.
We further decorticate the remaining lamina and transverse process for better fusion. So finally a closure was done and a drain was placed in situ. This is a very complex surgery that required delicate, meticulous placement and correction of the pedicle screws, and it took us 10 hours in surgery. This is a pre-op photograph of our patient, pre-op clinical photograph of our patient, where you could see right lateral bending was present, left iliac crest being higher than the right, a razor back hump deformity, a prominent right-sided curve, and this is the immediate post-op clinical photograph at day 3, which shows this convection to be absolutely absent. Adding to this, she had improved coronal balance and a height gain of 6 centimeters from 130 centimeters to 136 centimeters. This is the immediate post-op operative photograph. This is the AP view, immediate post-op and post-op X-ray. This is the pre-op lateral view, post-op lateral view. We can see that the Cobb's angle that was 91 degrees has now been reduced to 32 degrees, which shows a 65% correction in the curvature. This is the follow-up X-ray at 18 months. This is the immediate pre-op AP view, and this is the post-op at 18 months, which shows a 32 degrees curve correction is still maintained, which is a very good thing as our curve is non-progressing. This is the immediate post-op X-ray that was done to check for bone graft placement. This is the bone graft that was placed, and this is at 18 months, which shows a very good posterior lateral bony fusion is seen, which is very similar to our illustrated diagram. This is the follow-up at 18 months, at pre-op and post-op at 18 months. Shows an improved coronal balance. This is an immediate follow-up on Adams forward bending test, which previously as shown by Dr. Rishabh, we could see a rib hump that was present, now is significantly completely reduced at 18 months of follow-up. This is the pre-op X-ray, pre-op video, in which it shows tilting of the trunk, limping present, whereas a post-op, we can see how comfortably and confidently the patient is now after surgery.
So just a brief overview of adolescent idiopathic scoliosis. Incidence is 0.5% to 3% among pediatric population. As the name suggests, idiopathic, so etiology is unclear, but current research focuses on role of multiple genetic factors which are related to the progression of the curve. Now delayed diagnosis result in severe deformities, and these severe deformities are the indication for surgical correction, which produces significant cosmetic deformity, back pain and discomfort to the patient. Now pedicle screw instrumentation provides 3-column multiple fixation and allow major deformity correction in all the planes. So pedicle screw technique is the gold standard because of their documented superior biomechanical properties and improved clinical outcome. Now, yes sir? Yes sir. Rods can be there, but they are the severe curve. Rods are used when there is curve is progressive. So they are growth modulation rods which will prevent the convexity to develop, and concave rod will distract that concave part. So there will be growth modulation rods known as vector, vertical expandable prosthetic categories. They are in the research phase. So we have the review of literature. It says that curve greater than 50 degree in thoracic region and greater than 30 degree in lumbar region will progress at a rate of 0.5 to 1 degree per year even in adulthood. So if we left the patient untreated, the scoliosis curve will progress. So we have to correct it. Another article from Journal of Craniovertebral Junction Spine published in 2022, it says that regardless of the technique used, correction rate in scoliosis is often lower than 60%. In our case, it was 66%. So roughly correspond to that. Another article is a review article. It says the idiopathic scoliosis is the most common scoliosis, accounting for 80% of the cases. And in the MRI studies, neuroanatomical abnormalities are found in 20% of the cases in idiopathic scoliosis or in curve more than 20 degrees. Now this is a European article from the European Spine Journal, which says that concomitant rate of syringomyelia in idiopathic scoliosis is 4 to 8%. Combination of 2 or more intraspinal abnormalities often existed in patients with scoliosis with syringomyelia and cherry malformation, dystomatomelia and T3 cord syndrome. They have studied total 29 patients who underwent scoliosis correction successfully with an average age of 15.6 years. It concluded that prophylactic neurosurgery for intraspinal abnormality may be unnecessary in patients with asymptomatic or minor symptomatic syringomyelia or coexisting intraspinal abnormality. Now, another article focus on psychosocial issue or psychosocial impact on the adolescent female, because these type of adolescent female will have some psychosocial issue like low depression, anxiety, and low self-esteem and low attitude towards the life. So it is seen that deformity correction not only improve physical health but also improve mental health. With another article says that there are 73% reported satisfaction rate with the cosmetic design. Now, so the take-home message is AIS, adolescent idiopathic scoliosis, is a correctable condition. Diagnosis of AIS remains that of exclusion. However, between 2 to 12% of patients with diagnosis of AIS has neural axis abnormalities. Corpse angle more than 45 degrees generally requires surgical correction. Neuromonitoring reduces the risk of neurological complication and give good function along with root cause measures. So surgical correction of AIS can lead not only to curve correction but also improve or increase self-esteem and life satisfaction to the patient. Above all, these type of surgery require multidisciplinary approach, which needs cooperation from all the relevant department to perform such surgery, like orthopedic, anesthesia, radiology, and neurosurgery. So, on behalf of the Department of Orthopedic, I would like to take this opportunity to thank and express my deep regard to all the collaborating departments, anatomy, radiology, anesthesia for their kind cooperation. Our sincere regards and thanks to the CCR Reviewing Committee and management of Mahatma Gandhi University and University of Medical Sciences and Technology. Thank you.